has anyone or anything in the background, if you can please mute your microphone. Hopefully, everyone can hear me. Let me admit a few more people into the meeting.
We can hear you.
All right, great. Thank you for confirming. All right. All right, let's go ahead and get started. Uh, just a quick intro. I am Dr. Russell Brown, the medical director here at Avinia Behavioral Management, and we're a mental health staffing and education company. Um, resource um, psychiatrists and psychiatric nurse practitioners and physician assistants out to the mainly community mental health facilities and some primary care facilities. As a collaborator and supervisor, we are supposed to provide mental health education to our MPs and PAs, and so I've created this case study presentation series that's monthly right now, but will probably end up becoming biweekly fairly soon. Um, the resources we use are the four books: Psychiatric Case Studies for Advanced Practice, um, first edition by Prendergast and Jackman. The second text is Case File Psychiatries, sixth edition by Toy and Clayman. Um, third book is Adult Psychiatry Case Vignettes, second edition by Tavakoli and Sabur. And the fourth book is Child and Adolescent Psychiatry Clinical Cases, first edition by Amador. This morning, we're going to be discussing a case entitled "Lithium and the Older Adult," and I will go ahead and get started. Let me admit a few more people into the meeting. All right, and we can get started. All right. So this is case number 48 in the psychiatric case studies for advanced practice text. Uh, Lithium in the older adult. Identification. Uh, oh, and one more thing. If you have any questions, just go ahead and stop me at any time. But I'll stop periodically after a few sections in the presentation in the history and examination, and allow and ask people if they have any questions. But identification: the patient is a 72-year-old widowed white female who resides with her son and daughter-in-law since her husband passed away 3 years ago. She's being followed up for medication management in an outpatient psychiatric office. Her chief complaint is, quote unquote, "I feel good." History of the chief complaint: the patient is returning for follow up medication management of her psychotropic medications. Her mood has been euthymic on her current medications, and this consists of lithium carbonate 300 milligrams BID, Clonopin zero point 0.5 milligrams every 12 hours, duloxetine 60 milligrams daily, and lamotrigine 200 milligrams per day. So she's on those four medications. Past psychiatric history: the patient has a long history of depression, anxiety, extreme mood lability. Um, the patient reports her first suppressed episode occurring about 30 years ago when her mom died. She was subsequently hospitalized for 10 days and was prescribed psychotropic medication, but she cannot remember the names of those medications. She reported ongoing depression and anxiety over the years and was tried on various medications, including fluoxetine or Prozac, citalopram, and aripiprazole. She was taking duloxetine 120 milligrams daily, Ambien 5 milligrams at night, Ativan 2 milligrams in the morning, and Seroquel 25 milligrams at bedtime when she was initially evaluated by this writer 6 years ago. Because of her report of feeling like she could not sit well or sit still and had to keep moving, and her feet were being stiff at night, the Seroquel was discontinued. Um, these symptoms of akathisia were probably antipsychotic induced. Over the past 6 years, she's been cross tapered uh, to the current doses of the lamotrigine, lithium, clonopin, along with a reduction of the Cymbalta or duloxetine to 60 milligrams daily, which all have helped stabilize her mood. Um, there's no history of any suicidal attempts or ideation uh, or assaultive behavior. All right. Any questions so far about about this patient and her medication management regime? Uh,
No,
yeah, it looks like a medication management regime for someone who would be suffering from bipolar, but there's no indication that she has bipolar, just unipolar depression. And also, she had some akathisia and EPS type symptoms, uh, and they decided to they decided to stop the Seroquel, and it was only 25 milligrams. Um, I doubt if that medication may have been associated with those symptoms, but I guess it could be. Anybody have any thoughts about that? About EPS and a low dose Seroquel?
no,
All right. Well, if not, we'll keep going. Um, medical history: she has no known allergies. She fell on the ice in her 20s and hurt her back. She's had spinal surgery with rods and pins inserted. She continues to have intermittent back pain. She has a history of breast cancer with chemotherapy and radiation treatment. Uh, she has also been diagnosed with hypothyroidism and recently with rheumatoid arthritis. Her current medications include methotrexate, um, folic acid, levothyroxine, simvastatin, and montelukast (PRN). And that the montelukast is a immune modulator for asthmatic attacks or her asthmatic illness. Um, Her gait is slow and she walks with a cane because of an old foot injury. She fell and hit her head a year ago when she tripped on an area rug, and she denies any current unsteadiness or dizziness. Um, she she's had blood work drawn prior to the current visit, and the following results were abnormal. She has increased creatinine. It's a 1.01 milligrams per deciliter, where 0.57 to 1.00 is the norm. She has low estimated glomerular filtration rate, which is 55 milliliters per minute um, per 1.73, and it should be greater than 59. Her lithium level was in the high normal range, and this was 1.1 millimoles per liter, where zero point 0.6 to 1.4 is normal. The patient's thyroid stimulating hormone and her free thyroxine were in the normal limits. So it looks like she has some some borderline renal functioning going on. Um, and this is should be of some concern, especially since she is on the lithium. And this uh, and there are changes in renal function as we age, and that's why someone on lithium, you should be very careful and monitor the use of this medication and their renal functions very carefully. Um, History of drug and alcohol abuse is denied. Family history, both parents, both parents, both parents are deceased. Her mother had a family history of depression and was treated with ECT. Her sister has depression and is being treated with antidepressants. The patient has two sons, and she lives with one of her sons and her daughter-in-law. The other son is in the military, and he visits the patient infrequently. All right. Any questions thus far about the history, um, about the past history before we move to the personal history?
No questions.
All righty. Personal history. Uh, Perinatal, there's no complications or developmental delay. Childhood, no learning disabilities. The patient was able to make friends without any difficulty. Adolescence, she joins clubs. She graduated from high school. Adulthood, she met her husband in high school, married, had two sons, and was mainly a homemaker and raised her sons. There's no military or legal history. The husband passed away 3 years ago, and the patient moved in with her son. Um, she's had numerous friends, goes out to lunch with them regularly, and she still drives without any problems. All right. Trauma and abuse history, there is none. All right. So we've completed the history section. Um, Fairly standard case, elderly female with a history of apparent major depressive disorder that's being stabilized with some antidepressants and along with some mood stabilizers. Any questions thus far about the history?
No.
All righty.
No.
All right. So we'll go on to the mental status exam. Appearance, she's well groomed and cooperative. Behavior and psychomotor activity, there are no abnormal movement, but she does walk cautiously to avoid any falls, and she walks with a cane. Consciousness, she's alert. Orientation, she's oriented times three. As far as her memory, she's able to state the name and date and what she had for breakfast and how she spent the recent holiday. She was able to name the last three presidents. She was able to remember three objects after 5 minutes. Um, she was able to compute zero sevens, well, zero subtractions of three from 100, not zero sevens, but zero threes. Concentration and attention, she was attentive. Visual spatial ability, she was able to draw a clock face accurately. Abstract thought, her ability for abstraction was limited. She could not understand or interpret any proverbs. Uh, she asked, "What is a proverb?" So she did have that little bit of a challenge cognitively. Um, uh, um, Intellectual functioning is average. Speech and language, normal rate and volume. Perceptions, there are there's no abnormal perceptions elicited. Thought processes are logical. Thought content, no unusual content. Suicidality, homicidality is denied. Her mood is good. Her affect is congruent with her mood and is euthymic. Impulse control is good. Judgment is good. Insight is fair. Reliability is good. All right. Anyone have any questions regarding the examination, mental status examination? Anything glaring? The only issue I see where, on her abstract thought, she didn't, she couldn't understand or interpret any proverbs and actually asked what a proverb was. Uh, Everything else seemed to be with intact. All right, we'll go on to formulating the diagnosis. So, which diagnosis or diagnoses should be considered? The author here offers major depressive disorder in full remission as a diagnosis. Um, all right, let's go over the diagnostic criteria for MDD. We see this a lot, and everyone should know all of these, but we'll go over them just to make sure. You should have five or more of the following symptoms. Should be present during the last or during the same 2 week period and represent a change from previous functioning. And at least one of the symptoms is either depressed mood or loss of interest or pleasure. So you got to have depressed mood and decreased interest. Um, and note is that these symptoms do not include symptoms that are clearly attributable to any other medical condition. So you have to rule out any other situation going on in order to make the diagnosis of MDD. All right, so these are the criteria. One, depressed mood most of the day. Nearly every day is indicated by either subjective report, feeling sad, empty, hopeless, or observations made by others that someone appears tearful. And note that in children or adolescents, this can be an irritable mood. Number two, markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day, as indicated by either a subjective account or by observation. Three, significant weight loss when not dieting or weight gain, uh, a change of weight of more than 5% of body weight in a month, uh, or a decrease or an increase in appetite nearly every day. And in children, this consider a failure to make expected weight gains. Four, insomnia or hypersomnia nearly every day. Um, Five, psychomotor agitation or retardation nearly every day, um, which is can be observable by others, not merely subjective feelings of restlessness or being slowed down. Six, fatigue or loss of energy nearly every day. Seven, feelings of worthlessness or excessive or inappropriate guilt, which may be delusional nearly every day, and not just merely reproach or guilt about being sick. Eight, the ability to eight, the ability diminished ability to think or concentrate or indecisiveness nearly every day, either by subjective account or as observed by others. And nine, recurrent thoughts of death, not just fear of dying, or recurrent suicidal ideation without a specific plan or a suicide attempt or a specific plan for committing suicide. Um, B, these symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. C, as I stated before, the episode is not attributable to the physiologic effects of the substance or another medical condition. Um, uh, Note that these criteria, A through C, that were mentioned, represent a major depressive episode. Um, does anybody have any questions about these criteria or set of signs and symptoms that define depression?
I have a question. So when it says it's present during the same 2 week period and represent a change from previous function, that means that over a 2 week period, if they had five or more symptoms, that's when we diagnose it MDD.
Yes. Yes.
Okay.
Hmm. Any other questions about these criteria or concerns? Yeah, but yeah, you just have a change over a 2 week period with five of these symptoms, and one of them has to be the depressed mood or a loss of interest or pleasure. And then there's a criteria D. The occurrence of MDE is not better explained by schizoaffective disorder, schizophrenia, schizophreniform disorder, delusional disorder, or any other specified or unspecified schizophrenia spectrum and or other psychotic disorder. And then criteria E, which is most important about separating unipolar depression from bipolar, is that there has never been a manic episode or a hypomanic episode. Um, Note, this exclusion does not apply if all the manic like or hypomanic like episodes are substance induced or attributable to the physiological effects of another um, medical condition. So you just can't, with unipolar, there's no mania or hypomania, or if there appears to be a manic or hypomanic episode, it just can't be related to using a substance, such as cocaine or PCP or any other one of those illicit substances. Um, so, what is the rationale for this diagnosis? The patient previously met the full criteria for MDD, or major depressive disorder. At the time she was originally evaluated by the writer, she was extremely depressed and cried profusely. She was unable to enjoy activities. She had insomnia. She expressed feelings of guilt. She ruminated about past events, and she was unable to make decisions without checking, without checking with her husband or son. Um, those depressive symptoms have dissipated. She's been asymptomatic for the past year. Therefore, she's considered to be in full remission. Um, and let me ask this question at this point: since she's in full remission for a whole year, should she be kept on her medications, on her antidepressant and mood stabilizing medications, or not? Anybody have any ideas or thoughts about that?
I would say yes. Is that the reason why she's staying stabilized? Is due to her medication?
Yeah, I mean, she's stabilized obviously because of the medication, but a lot of people often ask, well, if I'm stable now and I'm in full remission for a whole year or for some period of time, can I stop these medications? So you think she's able to stop, or if you had a patient like this, would you start considering a tapering of the medications or a discontinuation?
Yes, I think I would taper first. I would start with taper.
All right. Well, the conventional wisdom is that you should just go ahead and keep them on the medication. I don't know what the exact time limit is, but most people just, I mean, they would just continue it. I mean, you could try, but um, conventional wisdom is if they've had one episode, one defined episode of unipolar depression and met all the criteria. Um, and then if she also has a family history too. So there's some genetics going on. So this isn't purely environmental. It's best just go ahead and make a decision and discuss it with the patient that it'd be in their best interest to continue their medication for some time. Okay.
Yes.
Um, mhm. In certain mood disorders like bipolar, if you just stop the medication, there's a effect called kindling, and the person may have another episode of mania or hypomania, and it would require a higher dose of medication or different medication to actually bring the person back to baseline because of that kindling effect. So it's always best to just, if the person's not having any side effect or any adverse effects, to just advise them that they need to stay on their medication to remain in remission. Okay. Um, Anybody got any questions or concerns about that? About the rationale for the diagnosis or the continuation of the medications?
No, but if you took a patient off of their, I mean, if they are, insisting on coming off their medications, there's nothing really we can do besides kind of wait it out, right? If
Right.
come
Yeah.
back,
Yeah. Yeah. But it's, the smart money would just, when you initiate therapy, just tell people that, hey, look,
right,
once you get well, the reason that you are well is because of the medication.
right,
And this is a lifelong illness that can recur. And it can cause a lot of disability, and at some points you can get sick enough to where it becomes fatal if you become suicidal.
right,
So the best thing to do is just, let's find the effective dose and let's stay on the effective dose. And I mean, she's on a lot of different psychotropics. I mean, you may want to just take it down to, I think she's on four. You may want to take her down to maybe two, but should remain on something.
okay.
Um, what tests or tools should be considered to help identify the correct diagnosis? You have the Hamilton Depression Inventory. You have Beck. You have other um, scales for depression that you can use. What differential diagnosis or diagnoses should be considered? They state here none indicated. I mean, you could consider a bipolar thing, but I mean, she didn't really have a true episode of mania. They refer to mood instability, but that was just probably irritability and sadness, and not necessarily anything manic or hypomanic. All right, let's move to formulating the treatment strategy. So, which treatment would you prescribe, and what is the rationale? All right, psychopharmacology. This is what we would do. We would reduce the lithium to 450 daily. I think she's currently on. Let's see what she is on. She's on. She's on lithium 300 BID. So she's on 600, and she's having some mild renal issues. So um, they're going to say move the lithium down to 450 daily, because the patient is 72 years old and her renal function may be decreasing, and she may be more likely to develop. She may be more likely to develop toxic levels of lithium. Although the dose has remained the same, her lithium concentration has increased since the last lithium level 6 months ago. Um, Additional reduction in the dose of lithium should be attempted in collaboration with the patient's primary care provider. Um, all right. We would also continue the Cymbalta at 60 milligrams daily, continue the Klonopin at zero point 0.5 milligrams every 12 hours, and continue the the Lamictal at 200 milligrams a day. What do y'all think about the Klonopin, zero point 0.5 BID in a person that's 72 years old? Anybody got any ideas about that?
And that could be contributing to because don't she have a couple falls, correct?
Right. Yeah. Yeah. I would probably wean her off the Clonopin. Um, um, Klonopin does have some anti-manic effects. I don't know if and sometimes I use it for people with chronic and severe panic disorder, but there's no indication that she has those, and she's elderly, and if her kidneys are going out, her liver may be having some issues. So I probably would decrease that medication and get her off of it altogether. In addition to lowering the lithium. Any other thoughts or feelings about that? Okay. Diagnostic tests continue monitoring the renal function, continue monitoring her thyroid function and her lithium level, evaluate her liver function tests since the duloxetine may contribute to hepatotoxicity, consultation, get with a primary care provider, um, and monitor the abnormal renal function with that provider. Referrals, she's referred to her PCP for a review of her abnormal renal lab results. Type of psychotherapy, there was none indicated. Psychoeducation, provide the patient with information about the risk of renal and thyroid impairment associated with lithium. A fact sheet about lithium can be assessed at NAMI from NAMI. Um, provide the patient with information about the risks versus benefits of Clonopin. Advise that there may be an increased risk for falls, as someone mentioned. In this case, the patient does not want to change her medication, but agreed to pay attention where she walks to avoid area rugs, etc., etc. And information about Clonopin can be found also at NAMI. What standard guidelines would you use to treat or assess this patient? We have standard guidelines from the practice guidelines for the treatment of patients with major depression, third order, and this is from www.guidelines.gov. All right, clinical note. Um, Although this patient is diagnosed with a major depressive disorder, she responded to medications that would typically be prescribed for the treatment of bipolar disorder, the lamotrigine and the lithium. However, she never presented with any hypomanic or manic episodes or any mood cycling. Her predominant outstanding um, symptoms were depressed mood and mood lability, which mainly were evidenced by crying easily and frequently. She never met the criteria for any bipolar spectrum diagnosis. There are considerable data supporting the use of lithium in treatment resistant depression, which this patient had. So there we go. Lithium can be used to treat the major depressive disorder, um, and it's been effective. Depakote is another agent that can sometimes be used in treatment resistant um, major depressive disorder also, as well as in this case they also added lamictal. All right. Secondly, risk benefit analysis requires that the patient be informed accurately in layman's term about the risk associated with prescribed medications, and this is the informed consent. When prescribing lithium, kidney and thyroid function must be monitored on a regular basis due to the drug's potential for toxicity. And some consumer organizations provide fact sheets to explain the risk involved, and this may be helpful in this respect. And that would be your organizations like NAMI or NIH. Individuals 60 years and older are at greater risk for drug induced nephrotoxicity. Alternative drugs that are non nephrotoxic should be substituted whenever possible. So, um, I mean, this patient's been doing pretty good on the lithium. Um, there may be a possibility that you could, you know, taper the lithium and see if she could just be maintained on the lamictal um, alone. Methotrexate may increase potential for depression and suicidal ideation. Since this patient's depressive symptoms predated her use of the methotrexate, um, it may not be a contributing factor in this case. However, this should be considered in cases where methotrexate presents with depressive symptoms. So once again, always look at illicit substances or current medications as a cause in aggravating or initiating any mood symptoms. Okay. Any questions about the case study at this point?
No questions.
All right, I'm gonna go over a few Q&As and then we can call it quits. I got a couple of questions I want to present. Let me see if I can find them here. All right, let's see. All right, we got a 22-year-old woman who's been taking a medication, the name of which she does not remember for her psychiatric condition. She complains of excessive thirst and urinating all the time. Which of the following is a woman's most likely diagnosis? We got five choices. We got bipolar, major depression, panic disorder, schizophrenia, and social phobia. Bipolar, MDD, panic disorder, schizophrenia, and social phobia. So, which diagnosis do you think she has based upon her set of symptoms of excessive thirst and urinating all the time?
I would say I guess it's schizophrenia.
Me
Uh,
too.
uh-uh. The answer is actually A, is bipolar.
Hmm.
This patient has symptoms of diabetes insipidus, which is a side effect of lithium used in the treatment of bipolar disorder. In diabetes insipidus, your body's antidiuretic hormone doesn't have a normal effect on the kidney, which is, and diuresis is to lose fluid, antidiuresis is retain fluid. In the kidneys, the antidiuretic hormone forces the kidneys to resorb the sodium as as the blood is passing through, and that resorption of sodium um, causes the water to kind of flow with the sodium back into the bloodstream and not go out in the urine. Um, what the lithium does, it competes in the kidneys for the sodium molecule, and lithium ends up getting sucked back in the blood, and the sodium goes out into the urine and it pulls water out. So people get dry, they become thirsty, and they urinate all the time when they're on lithium. So that's one of the side effects of lithium toxicity. All right, let's do. We have another question here. Match the following therapy to the clinical scenarios listed. Uh, One of the therapies is dialysis, and I did the question wrong, but anyway, the um, we have what 113. We have a 25-year-old male with bipolar disorder. He took too many pills and had two seizures, and now is in a coma. And you got various treatments for him: benztropine, um, Inderol, amantadine, dantrolene, dialysis, methylphenidate, and modafinil. The actual treatment for this patient or intervention would be dialysis. Um, dialysis, and the explanation is dialysis is used to treat lithium toxicity when it is severe and life threatening, causing seizures or coma. So, I guess the point here is lithium is an agent that you really don't want to. It's an old and gold standard. I mean, everything else in the treatment of bipolar mania and treatment resistant depression is based upon it, but because of its um, um, potential for toxicity, it needs to be monitored very, very carefully. And let me see, we got one more set of questions here. Let me see if I can find them. Um, right, question number 8. All right. You are treating a 27-year-old male with a diagnosis of bipolar disorder. He's currently stable on lithium 600 milligrams twice a day. His last lithium level was 1.0. Overall, he reports lithium is helpful and he is tolerating it well, except for some mild hand tremor, which he finds uncomfortable at times. Question one: what labs would you obtain routinely in this patient? Select the best three. We got TSH level, we got CBC, urinalysis, urine drug screen, uh, CMP, complete metabolic panel, and vitamin D. So out of those 6 labs, TSH, CBC, UA, UDS, CMP, vitamin D, what would be the 3 out of those 6 that that you would want to pick to monitor on a regular basis?
TSH,
Uh huh.
CVC, and CMP.
Yep, you got it right. The answers are A, B, and E. The side effects of lithium include leukocytosis because it causes a mild increase in your white blood cells. There's also diabetes insipidus, tremors, weight gain, and hypothyroidism. So it's important to always have a baseline thyroid, blood count, and metabolic panel, in addition to having follow up labs to monitor any changes in lithium treatment. So get your thyroid, get your blood count, and get your metabolic panel. And for anyone that's initiating or being maintained on lithium. All right. Question number 2: you order TSH, which comes back slightly elevated. What is the next step? Should you start treating for hypothyroidism? Should you stop the lithium? Should you obtain a free T4 or should you do nothing? Out of those 4 options, which would be the option that you would choose?
Number
I'm saying,
the third one.
Yep, obtain a
I'm
free
saying that
T4. Yep, yep. Lithium side effects and toxicity. Uh, oh, the answer is C. Yeah, obtain a free T4. Since the TSH is slightly um elevated, a free T4 should be obtained to evaluate further. Thyroxine is generally protein bound, so um, it may not have a direct effect on the thyroid stimulating hormone that it should, and that may rise a little bit. But it could be that you have enough thyroxine, but it's tied to protein in it, and you can't really measure it um, chemically when it's kind of tied to another tied to some protein. So you need to just assess the free T4 level and see if that's within normal limits and available, to act upon the thyroid gland. Um, um, and other tissues uh, in the body. What are the symptoms seen in lithium toxicities? Question number three. So we got four sets. You got confusion, ataxia, dysarthria, GI symptoms. You got confusion, ataxia, urinary incontinence, weight loss. You got confabulation, ataxia, ophthalmoplegia, weight loss, or you have none of the above. So once again, what are the symptom sets that you would see in lithium toxicity? Confusion, ataxia, dysarthria, GI symptoms, confusion, ataxia, urinary incontinence, weight loss, confabulation, ataxia, ophthalmoplegia, weight loss, or none of the above.
Would it be a B, the second one?
Nuh. The answer is actually A. Um, lithium intoxication can include cognitive changes, ataxia, dysarthria, and GI symptoms, which is nausea and vomiting, as well as diarrhea. I mean, you may have some urinary incontinence, but it's more like diuresis, and the person can become dry, and that may have been a little bit of of a spoiler there. But generally, in the toxicity, you would see the confusion, ataxia, dysarthria, and definitely the GI symptoms. Okay. Four, what are our potential options to address this patient's tremor? The patient has some mild tremor as a result of being on lithium. You have four options. You can start propranolol. B, you can lower the lithium dosage, reassess symptoms, and recheck the lithium level. C, you can stop the lithium abruptly. Or D, you can do A and B, which is start propranolol and then lower the lithium dosage and reassess symptoms and recheck the level. What would be
B.
what's the correct answer? B. Yeah, I would think that B would be the answer too, but it says actually D, which is A and B. Tremors in patients on lithium can be reduced with propranolol or the dosage of lithium can be decreased. I would probably not add another medicine to treat the effect of a medication, so I would just go with B myself. But the text suggests that you can add Inderol as well as lower the um, lower the lithium and recheck the level, or assess for the symptoms and see if they've gone and then recheck the level.
Okay.
But like I said, my principle is if you don't have to, it's better to try to reduce the medication first and just keep the patient on one medication if you can. All right. Does
Hmm.
anybody have any questions about the use of lithium in the elderly with depression? No parting shots, no similar cases. I doubt. Does anybody out there have anybody on lithium? It's such an older drug. A lot of people don't really use it as much anymore.
I don't have any patients on lithium. The last patient I had on lithium, she took herself off of it and she's doing a lot better, she says.
Hmm.
Hmm.
Yeah. All right. Well, hey, if there are no other questions or comments, we'll go ahead and end this case study review. And I think I've already picked the one for next month. Will be it'll be you know I think that one's entitled. Let me see. Uh, treatment after rehab for opiate addiction. So we'll be looking at dual diagnosis case and what's done for someone after they've uh, been started for had an intervention for opiate addiction, and how we treat the residual symptoms or any ongoing psychiatric disorders. Okay.
All right. Thanks,
All
Dr.
right.
Brown.
See y'all next month.
All
Bye
right.
bye.